Okay, we're going to go ahead and get started. I want to welcome all of our attendees and welcome back to many of you who have been attending all of our continuing professional development sessions. In the 2025 CPD series, we really wanted to take the opportunity to revisit core concepts in orthotics and prosthetics education, and also share how we currently approach these topics at Baylor College of Medicine. By the way, my name's Sally Kenworthy. I'm on faculty here. I'm filling in for Ashley Mellon, our program director. She usually hosts these, but she is at a meeting right now. We sent out a survey at the end of last year to try and gauge where the biggest perceived academic and practice gaps are. So thank you to everyone who filled out that survey. During these sessions, we'll be highlighting many of these areas. We really want these sessions to be interactive, so we hope that you'll share your thoughts on how clinical practice differs from or aligns with what we're sharing in the classroom. Feel free to use the chat or unmute yourself to answer questions from Lisa. I know she has some polls for you guys prepared for the presentation, so be prepared to do that. A little bit of housekeeping. Everyone in the email with the invitation should have received a link to the post-session survey and to the folder where the recordings will be posted. Make sure that you take the survey for this session within 30 days. You can take it after that, but you won't receive CEUs. We try to turn those over to ABC in a timely manner. And if you're not able to attend a future session live, you can watch the recording and complete the survey and then still receive the credit. So there's a little link in the folder. There's a folder link in the email that was sent to you with all of the previous recordings if you missed any of our previous sessions. Let's see here. I'm going to just mute a couple people there. And then finally, our CPD sessions moving forward are going to be on the Teams platform. So if some of y'all were hopping around on Zoom, we apologize. Baylor switched from Zoom over to Teams recently. And so all of our reminder emails will include the Teams link, and we'll send it out a few times so that you can watch as many of these as you can. With that, I'm happy to introduce our speaker for today. Lisa Abernethy is an assistant professor and associate director for clinical education here at the Baylor College of Medicine Orthotics and Prosthetics program. She teaches our content on cranial remolding orthoses and is actively engaged in research related to patient outcomes for this important treatment. Additionally, she has been an ardent supporter of policy change in relation to insurance coverage of this treatment, most recently testifying at the Texas State Legislature to bring positive change to insurance coverage in Texas. So please help me welcome Lisa.
Awesome. Thank you. So thank you for the introduction as well. You already covered some of the stuff I had on here. So like Sally said, I used to work as a cranial team lead in a pretty large clinic. I don't currently see patients anymore, but I try to stay active in the society and stuff related to cranial still. So I'm going to talk a little bit about this class. For cranial, it sits within what's called the SCOM class. So SCOM covers spinal and scoliosis as well. And we're going to cover that in the next session. But for this one today, I'm going to talk specifically about cranial disproportion and protective helmets. And this is all of the kind of competencies that my portion of the course aims to achieve, which you can see it's quite a bit. So everything clinically related to cranial disproportional. So this is kind of a broad overview just to start you guys out with so that you can see kind of everything that we cover. So we have a literature review, which I'll talk a little bit about. I have the lecture content is broken up into 3 different parts. And then I typically have 2 guest lectures and then the final exam and the practical. For the labs, I usually have 3 labs and then like a practice session. So the first lab, we work on landmarks. The second one, measurements and calculations. And then we go in on trim lines. And I'll talk about this a little bit more later too. For our textbook references, we use the Atlas, which there's a new edition coming out this year, and then the Lusardi. And we also review lots of literature. And so that is where I'm going to start us off with the actual content. So I have all of the students do a lot of pre-reading. So they're expected to pre-read the Atlas chapter first, and to read the clinical practice guidelines. And then we start off with basically like the evidence behind cranial before we get really deep into the pathology portion of it. Sorry? From there, you can see that we have an increase in publications over the years, which I'm sure most of you guys are familiar with, but we talk about kind of when you have a newer field, something that comes about recently, how the evidence changes over time. So I give them an overview of all those like really big key milestone studies and how those have shifted over time. Even the ones who didn't show like positive evidence, we talk about that and why they have those findings and things like that. So I was going to bring about specific stuff from our survey that you guys requested more information on. So as we go throughout this, I'm going to pull them out, but feel free to stop and ask questions as we go. So the first one was cranial is barely mentioned in school, but it's become a larger percentage of the clinical exposure. So I wanted to start with a question for you guys. Did you have more than, say, about 1 day of cranial education prior to treating plagio in clinic? And you can just put it in your microphone, whichever you prefer. When I went to school, I had 1 day of cranial education, but you're about to see it's a little bit different now. I see I've got a couple of none, yes, some. So we've got a mixed bag. Allison got a couple of days. In a few days. Yeah, so huge variation. And I suspect this is dependent upon when you went to school. So when I went, we had 1 day. Prior to that, which would be over 10 years ago, we may not have had anything prior to, gosh, 94 is during the Back to Sleep campaign. So before that, obviously, there wouldn't be anything. So from here, we can see the actual changes in percentage. So cranial remolding orthoses in the field of O&P, percentage of clinical time spent has increased 300% in the last 15 years. And of course, this is directly related to the Back to Sleep campaign, putting babies to sleep on their backs, and the increased use of restraining devices. So we're just seeing the pathology itself more and more. So it makes sense that it's going to become more and more common in our profession as well. The other thing we noted in the APC practice, the most recently one done, is that cranial orthotics are now the 3rd most common orthotic discipline. But note the 13% contains protective helmets as well. So 9% is for cranial remolding specifically. But that's still more than what you see with upper extremity prosthetics, which is interesting because historically that one always gets its own course. That one's still required in residency. So you are going to see that it's been changing in all of the schools to reflect the ABC practice analysis, where we're getting more and more education. So to dive a little bit into the content itself, we start off with basic anatomy reviews. We discuss the principles and history of deformation and talk about, the Clarion helmet was the first helmet in the United States. Go into the risk factors in a lot of depth, since that's what's contributing to the significant increase that we're coming across. And then the pathologies that we cover is both positional deformational and synostotic, and we talk about torticollis as well. So we've really been, at least I have been expanding our synostosis aspect of it recently. For the labs are interesting because there's only so much that I can feasibly do in the lab. So what I've decided to spend the most time on is to make sure that all of the students can find the landmarks that are necessary. They know how to take hand measurements, so that's circumference, cephalic index, cranial vault asymmetry. They practice this on foam heads, and on each other. And then they have to be able to draw trim lines on an untrimmed helmet and compare that to a rubric. And for scanning, we don't actually have a cranial specific scanner or something that could be used for cranial. So what we do instead is we watch videos and then we talk about the different types of scanners, the different procedures, that kind of thing. So it's worth noting on the bottom here that they do have a practical exam for this course. And on the practical exam, they're assessed. One is on their ability to spot what type of pathology. So they see a 3D foam head and they have to state what side it is, what presentation it is, most likely if it's positional or not. And then they also have to be able to measure, and we assess their technique and their accuracy of their hand measurements. So for part two, I always have this joke on my slides that we're going to cast each other just to see who will fall for it, but we don't do that anymore. So I once asked North America if anybody still does hand castings, and they said they get like one or two from really specific places, not in the US. But for everyone else, we now use scanners. So we talk about the different types of scanners, the procedures. I also go into insurance criteria in this evaluation portion of it. And I kind of do a comparison because I think it's important for the students to understand what types of questions they need to ask and the medical history, because insurance may want something really, really specific in order to approve it. So I make sure that they have a full understanding of that. I don't know for everyone's in a different state, most likely, but in Texas, one of our insurance says that we have to have documented that they turn the entire position of the crib 90 degrees, which is hilarious because you could just turn the baby. But silly things like that, you need to be familiar with the insurance requirements and make sure you include that in your evaluation. For part two, when we get into like the fitting of the helmet, the delivery, we really dig into the different types of helmets that are available. I'm going to show you a little bit more on that on a second, but we get into fitting goals. So you can see in the picture here, this one's from North America, but it goes over, it's a nice demonstration of where the gaps have to be for different head shapes. So we really go into that for all of the positional head shapes. I have a whole separate lecture as well on craniosynostosis, so they also have to know the fitting goals for synostosis. And then I have a rubric for the trim lines that everybody has to learn. For follow-ups, we go into skin conditions. For skin conditions, this is like rash, yeast infection, pressure ulcers, eczema. They have to be able to identify all of those, and then we talk about how to treat them as well. For graduation, this is where it gets a little bit interesting because there's not really a gold standard. There's not a published clinical practice guidelines, at least not that I'm aware of, on when it's appropriate to complete helmet treatment. As far as I'm aware, most places have the orthotist make this decision now. So I thought it would be interesting to show you guys what I teach the student and see if it differs a little bit. But what I go over is usually my goal was at least 50% correction. So if they achieve that, that's one of the things we look for, or if the measurements are within norm. The secondary factor is if the baby is reaching appropriate developmental milestones. So for example, are they starting to sit up now? Do they still have a sleeping preference on one side, or are they kind of rolling and turning and not showing a preference anymore? So once they've achieved that correction and that milestone, that's a good indicator that they may be ready to graduate. And the other thing that I have an asterisk on is at least 8 months of age. And this one, I think, is the most controversial part of this, just from talking to a lot of other clinicians. Some of them will just graduate them immediately, regardless of age, which is what I used to do. However, I had cases where patients came from other clinics where they had already graduated and then they regressed significantly. And because that happened, those were around 5 and 6 month old babies. Because that happened, I started looking at the growth and making sure that it was slowing down, which tends to happen closer to 8 months of age. So I did start taking that into consideration. But I do have an asterisk here because you don't have to go by that one. If they've achieved 100% correction and met milestones, then of course, like they're done regardless of age. There has to be gapping in the helmet. So if their head is perfect, there's no gapping, they're done regardless. So part three overview, a little bit on synostosis. This is when I dive into like specific pathologies. So synostosis, we talk about the fitting goals that we have, which you can see on the image here. I do include bicoronal, unicoronal, metopic, and sagittal synostosis in this. So kind of the biggies that we would see most commonly. So they need to understand where the holding points are, where the gapping needs to be, and then what the most common problem they're going to get with that helmet is, as well as trim lines. So for example, with bicoronal, the most common problem you're going to get is tipping. It's really going to tip over the eyes. So we discuss like the biomechanics behind why it's tipping and then how you would go about preventing that from happening, which of course a huge part of that is going to be the trim lines, the longer trim lines that are available at the mastoid hold. So we really dig into that discussion. And I didn't have this much content on this initially, but I just feel like it's becoming more and more common where people might get a random synostosis case, even if they don't typically see them. So they really need that information to fall back on if that does happen. For protective helmets, I have a smaller lecture on this one, and I'm sure everyone here who sees Cranial knows that they're just going to automatically give you all the protective helmets too. So I spend some time on measurements on that, when it's appropriate to do custom versus off the shelf, all that good stuff. And then hydrocephalus, we talk about the different types of shunts that are available and how you can build around those and work with them, and then how that correction is going to look different from other types of positional plagiocephaly. Okay, so we're on our next topic for the survey feedback. So for this one, it said the cranial helmet can vary significantly with manufacturer. I wholeheartedly agree. And this is when it gets a little bit tricky education-wise. The way that I've decided to go about it is I really focus on one, the materials. So like the Surlyn, the copoly, and the 3D printed, right? And we talk about the pros and cons of each material, what people most commonly use those for, and why. And then we dig into the different types of opening of the helmet. So I'm not really calling out any brands when we do this. I'm really just talking about the materials and the openings and why you might choose one over the other. So for like side opening, for example, I'm sure everyone knows that's most likely going to be used for positional, but in some cases it can be used for the second or third metopic helmet. For bivalve, that's more commonly used for post-op. But now we're seeing more and more bivalve with a 3D printed helmet. So we really go into detail on this, and I have samples of all of these different types of helmet. So we pass it around and the students have to practice opening these. I have some of those old school bivalve overlap hinged ones that are really difficult to open. So I make all of the students practice opening so they understand like just how difficult it can be to open and fit a helmet over a head shape. So I have everyone practice so they understand how important it is. The next one I wanted to talk about was the traditional versus the 3D printed. So this comment said, I feel like they're implying that in school we only talk about traditional. That was probably true like 6 years ago, but now that 3D printed is becoming much more commonly available, I at least teach a lot more about 3D printed. But I was curious from you guys, how many of you use primarily or like a large percentage is 3D printed? Just out of curiosity. And again, you can either type it in the chat or you can just turn on your microphone, whatever you prefer. Oh, wow. Carl is mostly 3D now. Almost 100%. It's going up even more, I feel like, since I've asked this last year. All 3D printed besides synostosis. Oh, this is fascinating. So, and for reference for you guys, every year I go to the Academy conference and I talk to lots of, cranial clinicians. I meet with all the manufacturers and I update all the information every year. But I haven't come across that many clinicians who do 100% 3D printed. So that's really interesting. Very cool. Well, y'all can give me feedback on my 3D printed section. And some just do like a mix or 1 to 2%. Ooh. Well, this will be interesting. Y'all can give me feedback since y'all see more than some of the other clinicians I've talked to. Okay. So I don't have all my slides on 3D printed here, of course. I have some of my overview slides instead, just to save time. But essentially, as of the last time I checked, there was 4 3D printed helmets available in the United States specifically. The 4 is the Autoblock Micro, the Sprouts, SureStep Sprout, the Tailey, and then the Starband by Orth America. So I have like the general overview that I go over with the students. So some of them can use several scanners. Some of them you have to have a STAR scanner or a TechMed. They have different liners for each one, and the type of liner that they use affects the breathability. So I have a row on the bottom discussing breathability because I feel like that's something you need to factor into your decision on what type. For the openings, this to me is also a huge factor. Some of them do side opening, which is kind of what we're used to, but some of them is bivalve only. And I did hear some feedback that the bivalve is a little bit more difficult to put on babies. When I was in clinic, I only really used bivalve for post-op and for babies who had like hydrocephalus or developmental delays. So I think that's an important factor. And then not all of them are technically approved by FDA yet for post-op design. For breathability, the Autobach one, this is feedback that I got when I asked around and I saw a whole session on this last year. They said that because the liner is everywhere, there's a little bit less breathability for the micro and for the sprout. But with the other two, they do not have the liner over the areas of gapping, which increases the breathability. So this is what I've heard so far. Yes. So then for like a general, oh, I see a comment, hang on. You said Sprout can use TechMed scans as well now. Okay, I'll have to update that then. I'm gonna actually make a note. Last time I talked, they said they couldn't use TechMed yet. So this stuff changes all the time. So I have to try to stay on top of it. Okay, so this is my general pros and cons of 3D printed helmets versus traditional. So for the pros, in general, they tend to be a lot more lightweight than the other ones, much less bulky, more breathable, and so far parents really like the cosmesis is what I've heard. And you also get a better initial fit, so a lot less time spent during that initial fitting and delivery appointment. For the cons, however, you still have that limited adjustability, even though it fits better up front. The cost can be a little bit more than the traditional, and sometimes it takes a few more days to deliver, which could be important depending on, the parent situation. I also heard a lot that food from the babies gets stuck in the tiny holes, and that's frustrating for the parents to try to get out. And then it can be very difficult to don the bivalve. So I would be curious, since some of you guys do 100% 3D printed, if you feel like that these are reflective of what you see in the clinic. I'll pause to see if we get any comments, but maybe I got it head on. No comments, okay. I'm gonna move forward. I feel like I'm going really fast. I'm trying to slow down a little bit. Okay, I got some comments in. So it says they feel like the 3D printed turnaround is pretty quick. Okay. I'm comparing it to traditional specifically, but I think that varies by the company. Whoa, y'all are going fast. In the case of North America, 3D fit is looser because it corrects the cranial vault height as well. And the sprout is fully lined, but it's pretty adjustable because of that. And families can put a shower cup over the helmet while they're eating. That's brilliant. I like the shower cup cap comment. Awesome. Okay, awesome. Thank you. Ooh, they keep coming. I'm gonna have to send a pull out to you guys to get more info. This is awesome. Okay. Autobook liner is removable and can be washed. Yep, I do mention that one. Okay, so we'll move on. This is a really interesting topic though. So importance of education and donning technique. This is another comment that I got from the survey. Ooh, still getting interesting comments. Okay, so for this one, when we talk about importance of education, I actually have a guest lecturer come in. She owns her own cranial specific clinic. And she talks a lot about patient management, kind of the psychosocial challenges that she comes across, and then fitting with different helmet styles. She also mentions troubleshooting fit in different skin conditions, and she has tons of pictures to demonstrate this and really like walks them through what they're seeing, what they need to do to treat it, what the different options are, and how to know what it is that's going on. So I like that one really good. And then she also goes into when it's appropriate to remake a helmet. This, of course, is one of the harder decisions we come across. And I feel like at least when I was a clinician, it's more frequent than I wanted it to be. But she discusses that on when she absolutely does have to do a remake, that she just can't adjust it appropriately anymore. And then she dives into craniosynostosis, fitting and troubleshootings as well. And I actually forgot to put a slide for my other guest lecture, but my other guest lecture is a physical therapist. I felt like it would be helpful to have additional information about torticollis. So she comes in and she goes a little more into depth about what torticollis is, the different ways it can develop, the different treatment options that are available, and then how torticollis can affect like the other milestones of the baby, which is really interesting, how it's going to throw off the alignment of the spine as well if it's not treated. So that's a really helpful lecture, I feel like, that I've been expanding on torticollis lately. Okay, for Mind the Gap. So I gave a really broad sweeping overview of the content, but there's really specific things that I am not able to cover, but that I wish I could cover. So the first one of those is we talk about trim lines and where they should be. So like less than a centimeter over the eyebrows and around the ears, that kind of thing. But they don't actually practice physically trimming the helmets. They actually used to do this in this course back when Jim was teaching it. However, it was very time consuming, and I'm sure everyone remembers their first attempt at like grinding out a little bitty ear hole. It was very frustrating for the students as well. In the end, we felt like it wasn't beneficial to have them trim actual helmets. So instead, I really focus on like the concept of where the trim line needs to be and how to know when it needs to be changed. So that's the first thing that I don't have. For troubleshooting and modifying fit, for this, I talk about when rotation occurs, why rotation occurs, but I don't go into depth about like pad placement, for example. So if you're seeing, we talk a little bit about pad placement, but I don't go really into depth. When it comes to rotation specifically, I feel like it's dependent heavily on the helmet and the pathology. And I don't know, I would probably need like a whole 5-hour lecture series to talk about with this helmet, they put extra gapping here. So you put a space here. With this helmet, they have extra gapping here. So I just feel like it's not really like efficient to use my time for that. So instead, I really just talk about the biomechanics of it as opposed to specific pad placement, if that makes sense. I do also talk about the density of foam, so rest-on foam and how that can be used in gapping versus pea-light foam, which is more dense and should not be used over gapping where you don't want to push. So we do discuss those sides of things. Yeah. And then lastly, how to don a helmet. I've been wanting to introduce this a little bit more. I've started passing them around and I'm going to put a model together so they can practice better. I'm sure when your residents first come in and they try to put it on a baby, it's like a whole thing. So this is something I'm actually planning to expand for next year. I'm going to try to order some new like foam heads that they can practice on. And then how to scan. It's just not feasible for us to buy a nice cranial scanner for the program just for this one class. So I don't have a cranial specific scanner that we can use. In the past, I've tried to use scanner that we had on hand, but I felt like it was not reflective of the actual experience. So I just didn't think it was helpful, which is why at the moment we just do videos. Yeah. Okay. All right, these are my references for the slides and some of the pictures that I used. And then I did have some questions for you guys. I feel like I went way too fast, sorry. But for some questions for y'all, do you feel like this matched what you were expecting was being taught right now, or was anything surprising or different from what you expected it to be? Okay, I'm seeing some comments come in. It says you teach more than y'all learned in school, so that's encouraging. Learned very little about synostosis and how to manage it. I don't think I learned anything of synostosis when I was in school, so I've been adding a lot about that. And that's primarily because I saw tons of synostosis. In the clinic, I had a new referral every single week. And I ended up sitting in on the craniofacial clinic with the surgeons every month as well. So I've been adding more and more on that content. Does anybody here see a significant amount of synostosis? No. Okay, so that one probably varies a little bit. I'm going to turn off my share screen since I'm just chatting now. Okay, so some of y'all see 10 to 15 post-op helmets a year. Some just see a few here and there. And some of you used to work with a craniofacial clinic. Yeah, I mean, it sounds about right. I think it varies a lot, but I feel like having that education just in case is going to be really important since those tend to be the most difficult cases. I feel like they're different enough from positional that you really need a specific topic on it. And Sally has a good question. Yeah, go ahead.
I posed a question in the chat. I would love to hear from y'all whether or not any of you are involved in training new clinicians or residents on cranial management. And kind of like what the structure is in your office. Is there a single specialist or are there multiple people that sort of manage it? It seems to me like most offices have like a target, like a single person, and then maybe like a secondary coverage person. But I'm always kind of curious to hear what training is like for these more specialized clinical areas.
I do a bit of craniosynostosis. And was this cranial health? Was this deformational or synostosis or both?
Anything.
Either.
Yeah.
Yeah. So I'm the main cranial practitioner at our office, but because I've been out sometimes, I've started training my practice manager in cranial, which has been kind of funny. But he started with the Ortho America course, which is pretty extensive. I want to say it was a good 25, 30 hours. And then I was starting to just pull him in to assist and shadow with patients right now.
Do you have any kind of structure that you try to follow? Like if now that you've trained someone at least, like do you start with just follow-ups and like when do you kind of transition someone to scanning on their own, doing all the medical history stuff?
I started with evaluations just to get the like big foundational topics, and then he shadowed me for a couple of those. He scanned with my observation, and then we'll start doing adjustments, I think, together, and then we'll definitely start him with like more mild deformational cases, and then go from there as he's comfortable.
Yeah, very cool.
I've been reading through y'all's comments, which are really interesting. I feel like it's common to learn most of cranial, like in person, on the job. Yeah, which makes sense. So I have a quick question. Since so many of you guys do 100% 3D printed, do you feel like the part one information of like the pathology and evaluation, do you feel like there's really any difference with 3D printed? Because I feel like it doesn't really have a significant difference until you get to the fitting and the trim lines portion. Just a thought. No significant differences for Carolyn. Evaluation piece is the same. Just the scanning protocol is different. Yeah. No trim line adjustments. Yeah. Oh, that's true. Gosh, you guys, I used to pre-trim everything for like hours because I had so many. That is hilarious to me that y'all don't have to do that anymore. That sounds nice.
Yeah, I mean, I would love to hear if somebody who has done, regular thermoplastic versus the 3D printed, how much time per helmet do you think that saves you? How much time do you think you would have saved per helmet, Lisa, in like
Oh man, a lot of time. Probably
Carolyn said an hour.
per an hour. I would say 30 minutes minimum per helmet. But if you do 500 helmets a year, like it's a lot of hours.
It really is. That's such a big thing I wouldn't have thought of. I have no, like, really no cranial experience, so it's really
Yeah.
interesting.
It's huge. For me, I guess my biggest concern though, I haven't fit a 3D printed helmet for reference since I don't see patients at the moment. But my biggest concern was the lack of adjustability because I was used to having to adjust a significant amount. But I feel like that hasn't been a huge concern. I guess I saw really, really severe patients. And with those babies, like everything in the head changes, the ear shift. I was always concerned about like significant ear shift with 3D printed helmets. So I'd be curious if y'all feel like it's still appropriate for severe cases. Okay, some of y'all are intentionally doing less than 10 millimeters of asymmetry or more moderate cases. Okay, that's what I heard last, but I wasn't sure if that was still the same or if they've gotten a little better. Okay, people are still saying it's not great for more severe.
Oh, interesting from Amira. I assume, Amira, you're referring to the 3D printed ones that are tough to adjust inside the helmet.
Yeah. And I do talk
Yeah.
about that with the students that if for whatever reason the baby is not in the helmet for like a week or more and they come back in and there's a gap, there's a lot less adjustability because you go from a 1/2 inch of foam to like a 1/4 inch or even an 1/8 inch of liner. So if someone's really non-compliant, I mean, you would have to order a whole new helmet. And I don't think that has changed at all. There is one helmet, I think it was the Taily, that has multiple layers, which addresses some of it, but not all of it. If there's a width change, it still doesn't, like, it won't help with the width change, only a length change.
Yeah,
So we
and
do talk.
Carolyn has a helpful comment on the sprout.
Oh, okay. Because you still have the phone globally. Yeah, it's still not a 1/2 inch though. I believe it's still a 1/4 of an inch, but it gives you enough adjustability for non-compliant. So do y'all only use one? Sorry, I feel like I'm really stuck on 3D printed now. Do y'all only use one brand or do y'all switch between brands depending on like the family and the presentation?
Yeah, I'd be curious. I feel like there would be a lot of marketing considerations for the 3D printed stuff because it's so much more visually appealing, in my opinion.
Yeah, and since there's only 4, I can't really teach them without mentioning the brand. To
Right.
me, that's virtually impossible. So I know we're not supposed to cover brands, but I just don't see how I could and like appropriately prepare them. Yeah. Okay, looks like most of you pick a manufacturer and you stick with it. Well, that makes sense because then you know exactly what to expect. You just have to have appropriate education. Interesting. Cool. Okay, so any questions for me? I feel like I've been asking you guys more questions than typical. Or any suggestions? Is there a gold standard for the cephalic index severity scale? That's an excellent question. I totally forgot to mention that. No, there is still not a standardized severity scale. I do believe Academy is working on a new CPG. I don't know if I'm allowed to say that yet. But as far as a standard severity scale for anything, actually, there still is not one at this time. I think that's something that each company has their own and each CPG kind of has their own, but there isn't any agreement upon that. I discuss that with the students and I show them different types of scales, but I don't expect them to memorize values because of that. They just need to have like a general understanding of like 12 to 15 millimeters asymmetry and up is typically considered severe, but there's some variation there. And like greater than 100% cephalic index is typically considered severe, but really we're going off of that initial chart, and the standard deviations is what we discuss. And the insurance companies still use the Farkas and Moreau chart as far as I know, but there should be a shift soon towards the more updated version, which is one standard deviation over based off recent publications. I'm seeing if I missed a question. Sorry, hang on.
Some insurances have specific scales or something in their policy descriptions.
Yeah. Yeah, some variation of a scale and a summary plan. Yeah.
Oh, that's an interesting comment from doTERRA.
The outdated CR numbers work sometimes. This is true. Yeah, and then I believe from state to state, the Medicaids as well have different, will have different stipulations on requirements as well. So between, and y'all already know this, but between the private companies, I don't remember exactly what it was in Texas, but like Blue Cross, for example, was like 10 millimeters or greater, and then Aetna was 6 millimeters or greater, and then like so on and so forth. There was a huge variation. So I discussed that with the students, but that, of course, is just a conversation with the parents as well. And we would just document all of the different measurements. And I talked to the students about other measurements outside of CVA and CHOA scale. I talk about like ear asymmetry, the radial symmetry index, the volumetric measurements as well. But again, we don't have a severity scale for like volumetric measurements, even though it's starting to become more common. So we discuss that, but I don't expect them to like memorize volumetric measurements or the RSI values or anything like that. We just discuss them because those are not in any insurance requirements yet. But those might be used more commonly for right now for research, but hopefully over time it'll be used more for outcomes. So mostly linear is what I teach still. So Michelle said that when she saw the helmets were cash pay and they did not run insurance, that was clinic choice. That could also be dependent on the patient population. So if you're a clinic where you see like primarily Medicaid, in Texas, Medicaid helmets are a non-covered benefit. Therefore, you had to do cash pay. So that could be part of why the clinic made that choice. But if they did have patients who had private pay, maybe they didn't have a contract with those insurance companies. So and I would assume it's a smaller clinic if they didn't have those contracts. But yeah, that would be clinic choice. And I'm sure most have heard that Texas does now have CROs will be a covered benefit that's supposed to start September of 2025. So yay, really soon, super exciting that they're going to be covered. We're still working on what the reimbursement package is going to be. Don't ask me, I get a lot of text messages on that, you guys. We're working on it. So that's super exciting. We're the only state that doesn't cover CROs and Medicaid, but not anymore. Okay. I feel like we're coming to a close. What do you think?
Yeah, I think so. I appreciate everyone's comments and questions in the chat. It's super helpful. As educators, we want to make sure we're always trying to get them as best prepared for clinical life as possible, in addition to all of the other content we have to cover. And so the specialized areas, ULP, SCOLI, and cranial, can be particularly difficult to prepare students for. And it's also, these areas tend to like change super fast as well. And so we just really appreciate everyone's attendance and your participation. I went ahead and dropped the CEU quiz in the chat if you want to do that really quick. It's just 10 questions, I think. You have to do that to get your CEU credit. After this session is done, we will post the recording as soon as we can to the folder that's linked in the original reminder email. And we hope to see you guys at our next one. We really appreciate everybody. And thank you, Lisa, for putting that together. That was great.
Thanks.
Thank you, everyone. Have a great one.